Welcome to all who are joining. Thank you so much for joining us this afternoon. You're joining us for a webinar, Community-Based Approaches to Suicide Prevention, New Resources and Future Directions. And this is hosted by the Transforming Communities Priority Group of the National Action Alliance for Suicide Prevention. Again, a warm welcome to everyone who's joining us from various places in the country. As we get started, we'll turn our attention now for just a few moments to some information about the platform that we're using to orient you to our webinar platform. Frank, I'll turn it over to you.
Thank you, Avery. So if anyone experiences any technical problems, you can call our helpline at 781-530-4708. And if you have any questions or comments, you can type them into the discussion box in the upper left-hand side. And Avery will monitor this for content questions, and she'll answer those, and Dominica and I will answer any tech-related questions. And all of your lines will be muted for the entire webinar. And if you want to enlarge the presentation, you can click on the full screen button with the 4 outward arrows on the upper right to make the PowerPoint larger. And you can click on the full screen button again with the arrows pointing in to return to normal view. And that being said, thank you all for coming, and I'm going to turn it back to Avery.
Thank you so much, Frank. Again, welcome to everyone who's joined. You're at Community-Based Approaches to Suicide Prevention, New Resources and Future Directions. Again, thank you so much for joining us this afternoon. So I'd like to begin by introducing our presenters. We have 2 fantastic presenters with us this afternoon, both of them leaders in the field and definitely leaders in this conversation. First of all, we have James Mercy. He is the Director of the Division of Violence Prevention in CDC's National Center for Injury Prevention and Control. And in this role, he provides leadership to innovative research and science-based programs to prevent violence and reduce its consequences. Dr. Mercy has worked to develop the public health approach to violence prevention, including suicide, for more than 30 years. Welcome, Dr. Mercy. The other presenter we have with us this afternoon is Jerry Reed. Jerry Reed is a Senior Vice President for Practice Leadership at EDC and serves as the Director of the Center for the Study of and Prevention of Injury, Violence, and Suicide. In this capacity, he directs the National Suicide Prevention Resource Center, funded by SAMHSA, and co-directs with colleagues at the University of Rochester Medical Center in New York, the Injury Control Research Center for Suicide Prevention, funded by CDC. Other duties include serving as a founding member of the Action Alliance for Suicide Prevention, the public-private partnership advancing the National Strategy for Suicide Prevention, and overseeing the Zero Suicide Institute at EDC. Dr. Reed has worked in the field of suicide prevention for more than 21 years. Thank you both so much for being with us this afternoon. I also want to acknowledge that, that Bob Gebbia from AFSP is not able to be with us this afternoon. He had originally intended to present with both of our presenters. However, he's unable to attend, but I want to acknowledge his role definitely in forming this presentation, and he is certainly here with us in spirit this afternoon. And as you hear in the continuation of this presentation, has certainly played a very important role in the developing of the Transforming Communities paper. So again, thank you to both of our presenters for being with us. Now I'd like to share a little bit about what you'll learn this afternoon. So the real point of this webinar is to introduce you to 2 new resources. Many of you have no doubt reviewed these resources already. First of all, Transforming Communities, Key Elements for Comprehensive Community-Based Suicide Prevention. This document was just recently released, and many of you received a link to that document for your review. The second resource is Preventing Suicide, a technical package of policy, programs, and practices. And you'll get to hear more about both of these documents, both how they were created, what's inside them, and also how we envision them being used together. And also we'll talk about future directions for community-based suicide prevention in light of the release of these 2 documents. So as we get started, we'd like to actually go now to a quick poll where we want to hear a little bit more about all of you who've joined us this afternoon. Just very broadly, we'd like to hear the fields that you work in. So we have public health or suicide prevention at the state level, public health or suicide prevention at the national level, if you're a mental health professional, if you work in an education capacity, perhaps in K through 12 or in higher education, or if you're in another community-based organization or setting. So just to hear a little bit about where you're coming from, so we know a little bit more about you as our audience this afternoon. So it looks like folks are contributing there. Looks like we have a good amount of folks with us from working at the state level and also at the national level in this conversation. A large variety of mental health professionals. And as you're continuing to add in, it looks like our largest group thus far is community-based organizations or settings. Like by far, that's our largest group of folks. So it's good to have folks here, it looks like, from a really wide array of different settings invested in this conversation and this topic. Thank you for continuing to add your votes there. Great. So I think it looks like that slowed down a little bit. So definitely the way that it's come in, it looks like here in our audience, the largest group is folks who are working in community-based organizations or settings. A small amount of you from educational institutions. And our next largest is folks who are working at the state level on this topic specifically of suicide prevention and public health perhaps more broadly. A variety of folks working at the national level also in this topic, and then a significant number of mental health professionals as well. And of course, these categories are really broad, and I'm sure that many of you overlap and work in a variety of different capacities. So thank you so much, all of you, for sharing a little bit more about yourself, and for folks also who perhaps didn't fit into some of these categories. Frank, you can close the poll now. Okay. So now I'd like to transition to our first section, which is working together to reduce the rate of suicide, which will really set the stage for talking more about both of these documents. And Jerry Reed will be introducing us in this first section. Jerry, I'll turn it over to you.
Thank you, Avery, very much, and good afternoon or morning to all of you, no matter where you might be. It's my pleasure to be here to speak a little bit about working together to reduce the rate of suicide. And I'd just like to reiterate the words of Avery earlier. Bob Gebbe has been a vital part of this process for the last year, working with us on this product, and has jury duty today. And you know, when your civic responsibility calls, you answer. So I'm going to do my best to represent Bob and his amazing work with our work group, and also share with you a bit of my own perspective as we move a bit further along. What I'd like to do is ask Avery to shift to the next slide, if I could, and I'd like to just begin to tell a little bit of what drove us to take on this task from the Action Alliance leadership, and it really had to do with the fact that, as many of us on this call know, we lose quite a few number of individuals to suicide every year. Last year, for which we have data, it was about 44,000, and that's certainly probably an undercount by some degree. And we've also, not only do we lose people to suicide, many make an attempt, many receive hospitalization care, many think of suicide. So the issue before us is great, and it's really important for us to address this issue in a scientific way, but in a thoughtful way as well, and also to really try to acknowledge that while the rates are increasing, there are still things we can do. And I always like to start by saying, you know, I've been in the field for 21 years, and 21 years ago we didn't even talk about the issue of suicide prevention, or have a webinar, or the products we have today, or the infrastructure we have today. So while we still have a long ways to go, we've come a long way. And I'd like to begin my presentation by at least acknowledging the path that we've taken thus far, and hopefully have you place yourself on that path at this point, but also by being where you are now, see where we're going. And where we're going at this moment is to pursue a national goal that has been established to reduce the rate of suicide by 20% by 2025. So we know that the rate of suicide in America is 13.0 per 100,000 in that neighborhood, and our goal is to reduce that rate by 20% by 2025. We've done that in collaboration with our colleagues at the American Foundation for Suicide Prevention, where they have Project 2025 that they are pursuing, which is in direct support of that goal, and the Action Alliance for Suicide Prevention has collaborated with them and shares that same goal, so that hopefully all of our efforts in the country can be flying in formation towards one united goal, which is to achieve that result of reducing the rate by 20% by 2025. How do you do that? You have to really do that, in the opinion of many who've been in this field for a long time, by looking at pockets of burden. You have to see where the burden exists in a community. You have to see where the burden exists generally, in which populations, in which settings, it's by which means, etc., and begin to target what we do to those areas where that burden appears to be the highest. When you look at the work of AFSP and Project 2025, I know they're looking at the issue of reducing access to lethal means and firearms in particular, because if you did, and you set a very conservative aim of reducing a certain number of lives lost to firearms, you could save as many as 9,500 lives. If you pursued work like we're doing with Zero Suicide and really changing the delivery of health care in large healthcare systems, you could actually reduce lives lost by as many as 9,200, again, with a very conservative estimate. And if you just worked with EDs and people presenting in the emergency departments for presentations that are suicidal in nature, you could truly reduce lives lost in that experience by about 1,100 if you began to quantify, using conservative estimates, the lives you could save if you delivered suicide-safer care. So I say that to you only to say that the goal of reducing 20% is certainly not out of the realm of possibility. And so what we want to do, and what our work has been guided on, is to focus on critical evidence-based areas where that burden exists and work in multi-sector ways with partners through collaboration. So not fly solo, where each organization does their own thing and we hope that somehow miraculously it all comes together, but really work collaboratively and collectively with one another so we can all be flying in formation and going in the same direction to reduce burden in those areas where it's highest, so we can see the collective results that are within our means to produce. I'd like to ask Avery to click the next slide, please. So what happened about a year ago was the Action Alliance for Suicide Prevention, when the executive committee met, entertained the prospect of creating a Transforming Communities priority working group. And many of you probably already know we have a very robust zero suicide program which works on transforming healthcare systems to deliver suicide-safer care. And we have anecdotal research that seems to suggest, and anecdotal experiences, that when you deliver comprehensive bundled care in the right manner, you can significantly reduce the burden of lives lost in a healthcare setting. Why shouldn't that same approach apply in the community setting? So the task force, the Action Alliance co-chairs, and the XCOM itself tasked us to really bring together a diverse group of individuals from across the country, from the nation down to the community and everything in between, and that we should really try to focus on how do you help states and communities who want to do something about suicide prevention that are outside the healthcare system. How do you really help them deliver suicide prevention in a way that has the best chance of reducing lives lost to suicide, getting people the help they deserve, and as I said previously, working towards the achievement of the goal of reducing suicide by 20%. So the document that we were tasked to create was really the how do you engage communities. And Dr. Mercy is going to talk in a little bit about some of the what you can do once you've engaged communities in the right way. Next chart, please. So the overriding principle of what we do with the Action Alliance for Suicide Prevention is to advance the objectives of the National Strategy for Suicide Prevention. Many of you know that strategy was written in 2012 and released. It was originally written in 2001, but updated as the science and the practice and the infrastructure advanced. And there are 13 goals and 60 objectives that are part of the national strategy. And they address community, and they address treatment communities and hospital settings, and they address surveillance and research and evaluation, and they also address postvention and aftercare. So this product is more about the community side of the coin, because we've really covered the healthcare side. At least we've gotten a good start on the healthcare side with zero suicide. Next chart, please. So the document that I'm about to talk with you a little bit today is the how communities can carry out suicide prevention efforts. How do you get a group of passionate individuals in a community to come together and effectively do something about suicide in your community? For years, we've had strong advocates and champions and survivors of loss or survivors of attempt coming together and doing amazing things at the community level. And frankly, it's what turned the light on, frankly, in suicide prevention. It really brought this public health issue to the attentions of our policymakers, et cetera, so that we now have a national resource center, a national lifeline, a national strategy, an Action Alliance for Suicide Prevention, and I could go on and on. The Garrett Lee Smith Memorial Act program that many of you have probably been a part of in your community, in your tribal community, or on your college campus. But we never really had a definitive how do you do it, and why do you do what you do. And then, as I said earlier, Dr. Mercy will talk a little bit about what communities can do based on the recently released document from the Centers for Disease Control. Next chart, please. So the document that I'm going to talk with you about just a little bit right now is the document that you see on the screen, which is Transforming Communities, the key elements for the implementation of comprehensive community-based suicide prevention. And in many ways, what we tried to replicate, at least in format and in framework, was the tremendous work that was done by our colleagues in the Zero Suicide community, where they identified 7 components of suicide safer care. And they tried to quantify that so any health system who wanted to make changes knew they had to lead, they had to train, identify, engage, treat those who were in their treatment facility, make certain that the transition when someone leaves those communities was done well, and set a framework or a goal of continually improving the delivery of those services so treatment for the next patient would be better than treatment for the last patient by virtue of what we've learned. So we use that same kind of concept when we wrote the document that we're talking about today. Next chart, please.
And as we progress here to the next chart, just a quick note to folks on the line. Thank you for those who are using your question and answer box there on the part of your screen to send us questions. Please continue to do that throughout the webinar. We will have a robust section at the end for questions and answers. So we are taking those questions and reviewing them, and we'll share them with the presenters towards the end of this conversation. So please continue to use that question and answer box there as your questions arise during the presentation.
Thank you, Avery, and I would just reiterate, we're all in this together, so your questions really do inform the next steps that we take collectively as each of us perform our own individual role, which hopefully contributes to the collective goal of reducing lives lost to suicide. So I'd like to talk just a little bit about how we developed the guide that's being released and we're speaking about today. Next chart, please. So first and foremost, the National Action Alliance created the Transforming Work Group, and Dr. Mercy, Mr. Gebbe, and myself agreed to co-lead this particular work group, and we were fortunate enough to develop a great group of individuals from communities, states, private sector programs, private sector initiatives, and really brought great minds together. And We basically met weekly by conference call. We had several smaller meetings of steering committee members or task forces who had worked on a specific task or project that they were asked to do. And then we met together face-to-face at the end of our project to kind of review where we were and begin to put, cross the T's, dot the I's, and put the document together, so to speak. What was most important, I think, rather than recreating the wheel, is that we all know that there is so much out there already, both nationally and internationally, that talks about what communities can do to reduce burden. And just to name a few, we certainly had the Air Force program that guided a lot of our work. We had the European Alliance Against Depression, which was successful and had outcomes in the desired direction. We had the Model Adolescent Suicide Prevention Program that worked with a Native American tribe and showed how that work could reduce attempts in that community. We've certainly had plenty of guidance that came out of either the Suicide Prevention Resource Center, the CDC, the World Health Organization, or most recently the International Initiative for Mental Health Leadership, which is a multilateral gathering of nations where suicide prevention and mental health initiatives are spoken about so we can learn from each other across the globe on what seems to work in a lot of these areas. We also have registries. Some of them are best practice registries about suicide prevention. Some of them are just best practices registries in general about injury prevention or violence prevention. But many of those programs also had outcomes that were suicide prevention related and warranted a look by us. And then there are larger community health improvement type models like the collective impact model or community health improvement navigator model out of CDC, and foundations like the Robert Wood Johnson Foundation have done things. So our strategy was to look at all of those from our work group, kind of read over them, cluster them together so that these individual task forces could kind of go through them and glean what were some of the common factors that were present in each of them. And then eventually, when we finished the entire review, we had a pretty good grasp of what the components of these just varied initiatives from around the globe really were. And we also looked at the literature. And so wherever there was a really comprehensive review of the literature that gave us really good clues about where there was a robust body of evidence that said what worked, we certainly took that into consideration as well. So we developed that review, we conducted that review, and came up with our synthesis. And at the end of the effort, tried to narrow that down to 7 key elements for comprehensive community-based suicide prevention that should guide planning anywhere and implementation anywhere as kind of a place to begin. So we just don't start wherever one person's passion might be, but try to give a roadmap to begin so that the work we do would yield the results we hoped for. Next chart, please. So the document and how it's organized is what I'd like to talk to just a bit. Next chart, please. So what we've done in the document, and when you read it, you'll see it, we've given you an overview of the reviewed program. So everything that we reviewed is summarized in the document, and it gives you the guidance and the models and the goals of that effort and some of what the salient criteria for that particular model were. We also describe in great detail the 7 elements that we settled on as being essential for any effort anywhere that wants to try to engage their community to reduce the burden of suicide. And then we have several appendices for all the programs that provide guidance and the models reviewed and the individuals who were kind enough to give up their time to help us put this together. And I'd be remiss if I just didn't put a slight call out to my colleague Maggie LeBray, who was just a magnificent writer who put all of this together for us so that we could present it to all of you. So Maggie, if you're on the call, I certainly appreciate your gesture. Next call, please. Next chart. So where we ended up, what are the 7 key elements that we feel very strongly make up the key elements that any community should be looking at when they are thinking about coming together to do something about suicide in their community. First is unity, and this is a theme we found throughout the documents that we reviewed, and what that really speaks to is a group of people who have come together with a common purpose, who want to build momentum and shared vision around reducing suicide wherever they live. Planning, the second issue. Everything that we looked at seemed to suggest applying a strategic planning process that really lays out the situation in the community, the magnitude of the burden, what's already going on, what's not going on, who's already at the table, who's not at the table. You know, all of that fed into what really screamed loudly to us that you have to have a strategic planning approach as you go through this work and follow that roadmap as you do the work, because if you want to improve and if you want to strengthen something you may have missed, it's really important to know what you've done already and what might not be contributing to the degree that you had hoped it would contribute. Integration is the third element that we came up with. And really the point on this one is no one evidence-based practice will solve the problem in your community. The data will speak loudly and clearly to you that there are probably multiple burden areas, high burden areas, that warrant intervention and action. There are risks that can be reduced and protections that can be enhanced, and you want to look very comprehensively at all of them, and not, if you will, as we did in the early days of our work in suicide prevention, and it was absolutely where we were at that time, but think that one solution in and of itself will make the kind of contribution to burden reduction we have in mind. You want to make sure that the interventions and the approach that you take fit with your community. What you need to do in a tribal community may be very different than what you'd need to do in New York City. How you address access to lethal means in a Western state may be very different than how you address reduction to access to lethal means in your state, depending upon the laws or the regulations or whatever in that particular community. And also, it may be around the world, and we certainly saw this, that while lethal means in terms of firearms may be a significant factor in our country, it's not a significant factor in other countries whose data we reviewed or whose plans we reviewed. So seeing how they approach the issue of reducing access to lethal means was very informative for us, and I think will help all of us as we try to make sure that our work fits with our community. You'll find some really good information in the guide that talks about how you make sure that context and culture and readiness are certainly part of your thinking, because if they're not, the intervention itself will not have the success that you hope. Communication, the more robust and transparent you can be with your community about why you're doing, what results you're seeing, who's being engaged, who is using their pulpit or their platform to speak about suicide prevention and not letting it be singularly the voice of a coalition chairman is certainly to our advantage. So all of the players who you've identified as needing to come together to present that unity, the more they speak about their commitment to suicide prevention in their community, the more it reinforces the work of the community. Data is the sixth element, and I must tell you, 21 years ago, we had Whiskers, and Whiskers, of course, is the CDC data site that really presents the burden of death in a community, in a state, and we knew that people were dying by suicide, but we didn't know much more. We now know a lot more. We know about data sources that we didn't know about then. We have the National Violent Death Reporting System, which is present in over 30 states, and it's been around with many states for a long time, and the depth of that data is incredible, and you can learn things about the toxicology reports. You can learn about whether or not someone's been in mental health treatment or prescribed mental health medication or struggle with intimate partner violence. And that's broken down in many of these NVDRS states to the community level. So as you think about where is the burden and what is the strategy that your group should pursue and what are the interventions you can look to, that information is absolutely critical. And then tracking that data along the way will help you see whether or not your group effort is achieving the results that you're hoping for. And finally, it's about sustainability and not making this a one-time experience that as the members rotate off the committee basically just becomes silent and suicide is no longer an area, or suicide and prevention is no longer an area of concern with your community. So those are the 7 elements. I won't go much more deeply into it than that, but I will say the document that you will have the URL for does go more deeply into it, but not so deep that it'll be bedtime reading. I think you'll really find that the length of our descriptions are just right for helping you and your community get started. So I'd like to ask you, Avery, if I might, to go to the next chart. I would like to reiterate that these key elements are meant as broad guidance for the field. This is not literally a Google direction guide from point A to point B. It's going to require a group of dedicated people to think about each one, the significance of their contribution to the effort, and really put the effort into making sure that before you get started, you're on that solid piece of ice, which we believe those 7 elements, and not just we believe, but the data from all the reviews that we conducted suggest are vital elements for a solid community approach. I would also want to reiterate that this document in some ways tries to bridge the gap between theory and practice and provides an umbrella under which comprehensive community-level process can be organized. I've been doing this for a long time, and I was doing a lot of reflection before this particular webinar today. And I remember when we started, we just invited communities to send 10 people that they identified to a room where we, for the first time, were talking about suicide prevention in a collective manner, many of which had never talked about that subject before as part of their community, but surely never talked about coming together as a community to address the problem. And when I think about where we are today and the data we have available and the evidence-based practices and the infrastructure that we have available today that we didn't have available back then, I frankly think it's a new game, and I hope this product really helps those of you who are just getting started, or maybe those of you who are struggling with where you and your community are now. This might give you the solid footing that you're looking for to go forward. And then we certainly would like to see communities apply this guidance, but realize this is the beginning, not the end. Our commitment here at the Action Alliance and the Suicide Prevention Resource Center, and I certainly hope with my colleagues, and I feel confident I can say this at CDC with Dr. Mercy, and certainly with AFSP and Mr. Gebbia and the many chapters that AFSP has around the country, this is the beginning, not the end. We hope to populate a website, develop implementation resources, dive deeper into each of these 7 elements, and where we have good information, populate that website or populate that toolkit so we can make it even easier for those of you at the community level to do the work that is being suggested in this document. So next chart, please. What I would like to do at this point is transition the presentation from the how we're asking you to think about developing a community-based approach to some of the what you can do. And I'm delighted to turn this over to my good friend and colleague of many years, Dr. Jim Mercy, who's the director of the injury center down at CDC. He's been in the field for a very long time, the Violence Center, knows this topic, knows it nationally, knows it internationally, and it is my distinct pleasure to turn it over to him to talk about the most recently released technical package from CDC. So, Dr. Mercy, I turn it over to you.
Thank you so much, Jerry. It's always great to share. I was going to say the podium, but I guess I should share the phone with you. And welcome to everybody on the webinar. This past year has been a great experience working with Bob and Jerry, but also Avery and a host of other people that have advised us, given input to this document on transforming communities. And the thing that's unified all of us is this passion for suicide prevention. So it's just been a wonderful experience. As Jerry said and articulated, these two documents, the Transforming Communities document that Jerry just talked about, which focuses on the how, and the document I'm going to talk about, the technical package for suicide prevention, focuses on the what, very nicely and beautifully complement each other. You know, urgent problems require solutions based on the best available evidence. I mean, if you go to your doctor with an illness, my hope, of course, and your hope, I'm sure, is that that doctor has at their fingertips the best available evidence of how to address that illness that you have. The same is true for a community, right? We want communities to have the best available evidence for addressing suicide, and that's what this technical package that I'm going to talk about really focuses on. Next slide, please.
And as we transition to this content, I just want to say really quickly, Jim, again, just a reminder to folks in this next section, similar to the last, as you have questions about what Jim is presenting, please feel free to use your question and answer pod there to type your questions in, and we'll capture those for you.
Thank you, Avery. And as Jerry said, those questions are very helpful to us, so please provide them. The purpose of this package is to provide states, communities, businesses, or other organizations with the best available evidence in order to help sharpen their focus on prevention activities that have the greatest potential to prevent suicide. We do not have perfect evidence about how to prevent suicide, but given the urgency of this problem, we hope that they can focus and use the best available evidence that's available to them, and that's what this package is about. Next slide. I want to say a few things about the nature of this package and some of the innovations in it. First of all, it's not a pick list of evidence-based programs. It really does several things that are unique and important. First, it provides the strategies that underlie suicide prevention, the basic strategies. And when you see them, for those of you who've worked in the field for a while, most of them will be very familiar to you. In doing that, it also promotes a comprehensive thinking about prevention. The idea that we can't necessarily rely on one strategy to prevent suicide, but need to use complementary strategies together in a comprehensive fashion to prevent suicide. Another important aspect of this package is that it includes policy, not just programs. Policies are a very important tool in our efforts to try to prevent suicide. So policies that could be at the state level, at the community level, that could be passed by legislators are included, as well as organizational policies, policies that are relevant to healthcare systems or workplaces. So all of those types of policies are reflected in some way in this package and are an important complement to the various programs we talk about in suicide prevention. And the other issue is that the package really articulates this theme that Jerry spoke to, and that's the role of diverse sectors, of working together, of taking a multi-sectoral approach to suicide prevention. Next slide. Well, how is this package organized? Next slide. It's really organized around three key components. One, the strategy that I already alluded to. That is the underlying preventive direction or action that can be taken to achieve suicide prevention. Second is the various, and there's often more than one approach that can be taken to advance a particular strategy, and that may include programs, policies, or practices. And then it articulates the evidence supporting the various approaches that are reflected in the document. it's important to note that this evidence is not intended to be an exhaustive review of all of the policies or programs that could potentially impact suicide. But we chose what we thought were the best examples, the examples which had the best evidence for having some sort of impact on suicide or risk or protective factors for suicide. Next slide. There's a couple of cross-cutting themes reflected in this package. One, as I said, is that these strategies and approaches are designed to work in combination and reinforce each other, not alone. And we think we can have our greatest impact on suicide and suicidal behavior by choosing a set of strategies that reinforce and complement each other. And secondly, the strategies are arranged in order of the level of potential impact. Now let me explain that a little bit. It's really what our best guess of the level of potential impact on population change in suicide and suicide rates. So in public health, we're most interested in reducing suicide rates in a community, in a county, in a state, in a city, at the population level. And so that requires many different approaches to achieve. But the order of these strategies, as our best guess, is if you could effectively implement these strategies, the ones at the top of the list are the ones we think, based on current knowledge, would have the broadest impact on population change. Next slide. So this slide presents a summary of the technical package and of the strategies and approaches that are contained within it. And I'm just going to go over it very briefly, but it'll give you a sense and feel for the package. The first strategy is to strengthen economic supports. You know, an example is housing stabilization policies. We know in the housing crisis in 2008 that contributed to many suicides. And there's other evidence that the lack of stability in housing can contribute to suicide. So policies that help stabilize that and mute the impact of potentially losing a house or facing the stress of losing the house can contribute to reducing risk factors for suicide. So that's an example of a policy that helps to strengthen economic supports. That's the approach. The second one is to strengthen access and delivery of suicide care. The example that I use here is zero suicide. The approach of having safer suicide care through systems change is really exemplified by zero suicide. And we use the Henry Ford HMO example, which is the precursor to zero suicide, in here to show evidence for the effectiveness of that kind of impact. But it's just to show you that zero suicide also is a part of this comprehensive approach, and an important part of it, an extremely important part. The next strategy is to create protective environments. An example here is organizational policies and culture. An example of that is the Montreal Police that implemented a series of policies in that organization that helped to reduce high suicide rates that they experienced in that particular police department. Another strategy is promote connectedness. Of course, we all know about the importance of connectedness, and it actually cross-cuts many of these different strategies, but it's important in its own right for suicide prevention. And you know, peer norma programs such as sources of strength used in school systems contributes a lot to the connectedness that kids have to schools and families, and it can be a tool for reducing key risk factors for suicide. The next strategy is teaching coping and problem-solving skills. And you know, these skills, one of the ways these skills are engendered is through parenting, and one of the approaches here is parenting skill and family relationship programs. And those types of programs can be effective in reducing key risk factors for suicide. The next is strategies to identify and support people at risk. Gatekeeper training is the classic example here, but also this category of this strategy includes treatments to for people at risk of suicide and also to prevent reattempts, such as interventions that have been done in emergency departments with people who come in for suicide attempt to prevent them from reattempting. And finally, and also very important, is lessening harms to prevent future risk. You know, an example of this is safe reporting and messaging about suicide for the media. So that is a summary of the components, the strategies and approaches in this technical package of the best available evidence. Next slide, please. If you look in the document, in each section, you'll see the strategy reflected at the top, then a rationale for that strategy. The key approaches are articulated, as well as potential outcomes that we believe these approaches would impact upon, as well as, you can't see on this page, but paragraphs that address the evidence base to support the approaches that are reflected for this particular strategy. And we really hope that communities can use this sort of information contained in the package to help to articulate their plans for suicide prevention, and use the language in here to be able to demonstrate the viability of what they want to propose and to undertake in their own communities. Next slide. And finally, I just want to emphasize again that the strategies and approaches are ideally used in a comprehensive, multi-level and multi-sectoral way. I think a key message through all of this, through both resource documents, is that we need to work together, and particularly in this environment where financial resources are likely to be scarce, our working together, our partnership is going to be a key factor in success. One thing we emphasize in addition to that is monitoring and evaluation, because we want to learn from what communities do. We have to learn as we go. This is an urgent problem, and so the more we can learn about what is done in communities, that we can feed back to other communities and improve these two resource documents in the future, and other resources will be really critically important. And finally, just to let you know that the evidence base is improving all the time. In fact, since we developed this document, there's been new evidence that has emerged. So this is a living document that we will update as new evidence becomes available to reflect the current state of the science. So thank you very much for your time, and let me turn it back over to Avery now.
Great, thank you, Jim. So as we conclude now our review of these two documents, we'll transition into a poll, and Frank, if you could bring that up for us. We'd like to hear from you all who are attending a little bit more about how you might plan to use these two documents. As both Jerry and Jim have described, they're designed to work together, and we certainly hope that they'll be helpful to you. And so we'd just like to see your reflections on how you might use them. One of the options is to share it with your colleagues. Another is to use to guide strategic planning and selection of programs, policies, and practices. Certainly, again, there might be overlap here. And perhaps even to use to assess the strength of the current strategies that you're using. And I'm sure there are other thoughts too, which we'll hear perhaps during the question and answer section. And feel free to chat those in as well, other ways that you might envision using these. We'll give folks just a few moments there to answer. We see a variety of different ways that folks plan to use this. Certainly sharing it with others, which we appreciate, and of course a link to these resources were sent to all of you who have registered for this webinar, and we'll be making sure that you see those links again as well. And it looks like a great many of you plan to use it to really think about new strategies, programs. One individual chatted in ways to influence the community to think about suicide prevention, so thank you for sharing that. So I can see from the poll results here that you certainly share our enthusiasm for both of these documents, and as Jerry and Jim have both communicated, this really highlights a collaborative effort across the field and energy from so many different folks at a variety of different levels, including the folks who reviewed both of these documents, which I think is important to acknowledge. There was a robust review process as well to make sure that they truly would be helpful to all of you who are listening in. So thank you for sharing with us how you plan to use this. Frank, we can transition now out of the poll. So in this next section, we're going to talk a little bit about future directions, and Jerry, I will turn it over to you for that conversation.
Thank you very much, Avery, and Jim, thank you. The thing that I'd like to really emphasize in the future direction is what I said pretty much at the end of my presentation earlier, and that is this is the beginning, not the end. And we realized that we were asked by the executive committee to develop a paper that could be represented to them at their June 20th meeting, I believe it is, and really let them know what we're doing for communities who want to engage in suicide prevention. So I'm hopeful that this will be well received by the co-chairs. They have already preliminarily kind of given us a thumbs up, but I'm hoping that next steps are identified that we can pursue that will, as if you will, put more meat on the bone. So as you go to a website that might be designed for this initiative, you can find much greater information taking you into the documentation that exists for each of the elements. I would say what really helped me in this process was when you think about being at the community, wherever that community is, first off, we were fortunate enough in the process to hear a little bit from Colorado on a different project and got a chance to see the amazing work that Colorado, who is an NVDRS, National Violent Death Reporting System state, an amazing job that they were able to do with the data from NVDRS using Tableau as a platform where you can honestly see if there were 1,000 deaths in your community in the last year, you could actually see criteria and the related criteria that went into each and every one of those deaths that would certainly help guide you as you thought about where your burden exists and where your community coalition should start their efforts and strategic planning to begin to reduce that risk. Now, I know every state doesn't have that, but if one state can have it, then it shows me that it's not just a dream, but a possibility. And so the more we share with each other, and hence that's my future direction, or one of the points I'd want to make, the more we share those kinds of innovations that are happening at the state level or the community level, the better it's going to be for all of us across the country to encourage our epidemiologists or our state data folks to see if they can help us do the same. I also was very aware throughout this process that, we have a great deal of infrastructure in the United States as compared to what we had in 1996 to address the issue of suicide prevention. Every state just about has a state suicide prevention plan, a state coordinator. Every VA medical center has at least one suicide prevention coordinator, some 2 or 3. Every military base in the country, Army, Navy, Air Force, Marine, has somebody who's been identified as being the suicide prevention lead for that military installation. We have sheriffs. We have, local media. We have police forces. We have schools. I could go on and on and on. So I guess the next step that I would want to reinforce, or a future step, is let's be smart enough to reach out to the existing resources that are already there, community mental health centers, federally qualified health centers, just community health centers in general, and really bring to the table some of the assets that already exist, the substance abuse providers, et cetera. Bring them to the table so they can look at the data with you, and I'll guarantee you they're going to be quite surprised at seeing the data that shows the burden in the community they're funded to address. So it can engage conversations with coalitions that heretofore we haven't been able to engage. So I hope one of the future directions is much more salient coordination and collaboration amongst state and community coalitions and partners. But similarly, I would want to say at the national level, one of the things that made me very proud about this project was the American Foundation for Suicide Prevention and EDC and the SPRC and CDC and the NCIPC, the National Center for Injury Prevention Control, all worked together on this. It was public sector, it was private sector, and it was a nonprofit. All came together to marry our resources and our talent to send the message that no one of us is going to do this alone. All of us are going to do this collaboratively. So I'm hoping that because we now have a national unified goal of reducing burden by the rate by 20% by 2025, that we'll work together. We'll merge resources when we can and collaborate in trainings and webinars and product development as we should, so that we take advantage of the infrastructure that exists publicly, privately, and certainly in the nonprofit sector. So that's one hope that I have, and I do hope that, like Zero Suicide, we can generate the support from some of our public or private sector or nonprofit sector partners to help fund the development of material that will take this to the next level several times over, so that when you're ready to do something about suicide in your community, you won't have the difficulty in doing it. But I guess my greatest request of you is to don't think that, you know, the 2 or 3 coalition members that have been the loyalists up until now are the only ones that will come to the table. I'm really seeing where hospitals and psychiatric inpatient facilities and primary care facilities and nurse practitioners, if you get the right champion to represent their sector based on the data in your community, I think the miracles that will follow will speak for themselves. So I will close with that, and certainly I'd be remiss if I didn't thank everyone who had anything to do with this product. They're all listed in the back of our guide that we've spoken about earlier this afternoon. But this was all volunteer work and an amazing group of people who dedicated, you know, at least once a week to go through some of this literature or these programs to help us identify what those 7 key elements were across the board that we could share with you today. So Avery, let me turn it back to you.
Great, thank you, Jerry, for that summary and talking about next steps. One of the next steps that you heard Jerry mention a couple times now was the need for additional resources in addition to these 2 resources. So definitely some acknowledgement that this is not an end, but a beginning of a conversation. So I would like to invite you now to, if you've been thinking about particular tools that might be helpful to you in addition to these resources, to take just a moment and enter a response to that in your question and answer section there. Tools that you feel might be helpful to you in addition to these 2 resources, specifically on the topic of community-based suicide prevention, and to help you to realize some of these goals that we've been talking about. So if you could take a few moments there and perhaps enter some of your ideas, and we can share those out loud. We'll be able to see them here on our end. It's great to see your thoughts and suggestions on that topic. One individual responds, really any tools on, it seems like, how to get folks to work together and be invested in this topic. So one individual says specifically about city councils regarding the role of housing and access to housing. It looks like some of the things that we're seeing folks describe actually, I think, are addressed in these tools, which that's great. So it seems like some of what folks are looking for, some evidence about what really might work, and of course both of these documents kind of look at some of what is working right now. Again, I think many folks are expressing that it would be good to see templates perhaps about how to develop policies. So maybe based on some of this information, templates for that could be used to do those next steps. And some questions here or thoughts around how to really get communities to understand that this is a community issue across communities. So how to apply this information with communities to get folks invested. And folks are also submitting great ideas of tools that already exist. And of course, a lot of these, again, are listed in these resources. So we certainly look forward to you reviewing those and seeing how many wonderful resources were reviewed as part of this process. So as folks are continuing to add in their thoughts now, we'll transition to the next section of our presentation, which is to answer your questions. And many of you have been sharing fantastic questions across this presentation as both of our presenters have talked about these tools. So we'll transition now to some of those questions. And again, I encourage you to continue typing in your thoughts and questions, and we'll capture those and seek to have our presenters help us out with answering some of them. The first question, Jerry and Jim, that I would put to you about really both of these resources perhaps is both of them describe that it was a review of a variety of different programs and what seems to have evidence and be working. So the question I have is while these tools are about comprehensive suicide prevention, are the resources themselves comprehensive? So meaning, for instance, if folks who review these resources notice that a certain policy isn't included, for instance, as an example of what might work, does that mean that someone shouldn't promote that policy or shouldn't think about using that program?
Hey, Rita, this is Jerry. I'll be happy to take a crack at that, and I'll put my Suicide Prevention Resource Center hat on for the answer. First and foremost, by no means is the document that I spoke about or the one that Jim spoke about all-inclusive of all of the evidence that exists. We certainly don't have as much evidence in suicide prevention as we would like to have, but we have a lot more than we've ever had before. And I think with research funding from NIMH and with every Garrett Lee Smith grant being evaluated, we're building evidence all the time. And with zero suicide, the same thing is true. So I would answer by simply saying perhaps the easiest thing to do, if you detect that there is a certain degree of burden in your community with a certain population or in a certain setting or with a certain group of individuals, you might go to the Programs and Resources tab of the Suicide Prevention Resource Center and just type in that setting, that high-risk population or whatever, and every resource that we have in our resources and programs to include the evidence-based programs will be a response that comes up on your computer. And you'll not only have the evidence-based resources at your fingertips, but you'll have other material that is certainly creditable and will help you in your strategic review of the topic or the population or the setting as you think about what might be the most appropriate intervention for your community. So by no means is this a comprehensive list. There are many registries. NREP that SAMHSA oversees includes a number of resources that may not have been evaluated for suicidal outcomes, but certainly may have relevance to other outcomes that you're trying to address in your community. And like I said, I wholeheartedly, we just redesigned our website for the sole purpose of making it a lot easier for communities who are trying to do something to get a quick read on everything that's been done that could be helpful as they target a particular group in their community for attention.
And this is Jim. I would agree with what Jerry said and just emphasize again that the technical package for suicide prevention is not an exhaustive review of all the policies and programs relevant to suicide prevention. But I would encourage you, I think what the message we have is that when you're considering a policy or program, to really do your research to see and understand what the evidence is. And that's where what Jerry suggested about going to the Resource Center website and other resources and exploring that is very important, because we want communities to do what the best thing is. We want them to get the greatest return on their investment for their time and money in suicide prevention. And that's what these documents are really trying to emphasize.
Thank you both for your reply to that question. Another question a few folks have typed in about zero suicide, and of course both of you mentioned zero suicide in some way. So perhaps, Jerry, when folks look at the 7 key elements, how would you help folks to understand how these are different than zero suicide components, and perhaps the overlap or the difference there in the structure?
Thanks, Avery, and that's a great question. And when I think about what we're trying to do, I'll start with this picture. That my highest level thought is reducing the rate of suicide by 20% by 2025. So that's what I see when I look out there at the highest level. I would love it to reduce it to 0, but I also have to be practical about where we are. My aspirational goal is clearly 0. But if a mark on the wall of 20% rate reduction by 2025 gets us going in the right direction, I'm willing to go there. The next thing, I want you to just kind of think of an arrow coming down from that 20% line and think about zero suicide. And zero suicide was always designed for health and behavioral health care systems. It was not designed for community application. That's not to say you can't have a similar goal, but it's important to understand that the program was developed for health and behavioral health. So when we talk about clinicians' expertise in the delivery of evidence-based practices, or when we talk about making sure transitions are true warm pass-off transitions that result in a next day or next couple day appointment, or when we talk about leadership involvement of the system, we're talking about zero suicide in the healthcare system. But what we wanted to do, again, going back to that high-level goal, we needed to have something in place for communities. So the community-based guide that we've developed for you with those 7 elements, they didn't try to replicate the same 7 elements of zero suicide because communities are not boundaried systems. They don't have a single leader. They're not all the same. The evidence base required in one community may be very different than the evidence base in another community based on the burden you're trying to address. So I would just say that my answer to that question is I want to reduce burden. I want to have a framework for clinical-based approaches, which is zero suicide, and I wanted to have a framework with our colleagues for community-based suicide prevention. And then we called it the comprehensive community-based guide because theoretically what we do in the community should link to what's being done in the clinical setting, and anyone who's identified at risk who may be needing more than just a community intervention but needing a clinical intervention would go through the door of a setting that's prepared to deliver that suicide-safer care delivery, and at the end of the process is well on their way to recovery with their challenge being addressed effectively and efficiently by a well-prepared healthcare system. But it started at the community that was equally as well prepared. So that's how they differ. They're not the same thing, but in theory, they're trying to reach the same goal, which is to help both of those settings do its part to make a contribution to the 20% rate reduction.
Thank you, Jerry. In the comment section, we see a variety of folks still sharing a little bit about our previous question related to what they need. And there's a lot of questions related to specific programs and how some of this may relate to specific programs that they feel that they need. So that's good for us to note. We may not comment about specific programs maybe through this webinar, but it's good to record here some of the questions you have about that, certainly as we think about other things that we might develop moving forward. I do want to note there was another question about whether there would be any content on this topic at AAS coming up here towards the end of the month, and I do want to share with you that there are several sessions where this topic of community-based suicide prevention definitely will be highlighted. One at a pre-conference session that will definitely be talking about the key elements from the Transforming Communities document, and also there'll be some hard copies there for you to look at if you haven't had a chance to look at it yet in the exhibition area. So certainly to answer that question, some opportunities at AAS to continue this conversation amongst different folks. Jerry, there was one more question related to the setting of the goal of the rate reduction of 20% by 2025. And I think you did a great job there answering the nuance of how this is different, what's presented in these documents, to the zero suicide model and how these things connect. But several folks have expressed some question about how maybe that goal was arrived at and why we think that's the best kind of realistic goal for us to think about holistically, and how that, thinks about how we think about the zero suicide paradigm within healthcare systems in connection to that broader goal. So is there anything more you would say to that specifically about how that was agreed upon by folks and why we have energy around that goal?
Sure. I appreciate the question. I think it's another good one. The original goal that we had as part of the Action Alliance for Suicide Prevention when it was first launched in 2010 was to save 20,000 lives in 5 years. That sounded good, but it was really not something that was measured or tracked, or we had the metrics. And so it wasn't as concrete as we wanted it to be, and as much a part of our philosophical behavior, for lack of a better term, our practical behavior as suicide prevention and treatment experts. So it didn't really carry the weight. When the World Health Organization put out its Preventing Suicide Guide on World Suicide Prevention Day a few years ago, they set the goal of member nations reducing suicide by 10% by 2020. And so we looked at the percent versus the raw number issue, and shortly after that, and I'm on a steering committee with the American Foundation for Suicide Prevention, as they started thinking about their Project 2025 goal, and I would encourage anybody who hasn't, go to the AFSP website, afsp.org, and look at Project 2025. And the numbers I referred to earlier, you'll find on that website in terms of how they were ascertained through simulation in terms of the number of lives we could save if we were to introduce best practices in some of the high burden areas. So AFSP made a decision to set the goal of 20% by 2025, hence Project 2025. And it just seemed to me that if that's going to be the goal that AFSP set, and the World Health Organization set 10% by 2020 for member nations, we did a pretty exhaustive comparison of what's really the difference between a raw number and a year and a percent reduction in a year. And in fact, many more lives would be saved, and it's a far more challenging goal to set 20% rate reduction by 2025 than 20,000 lives over 5 years. So we presented that projection and that math, for lack of a better term, to the Action Alliance for Suicide Prevention Executive Committee, and received approval in our last meeting to modify the national goal to 20% by 2025 so that we'd be in sync with AFSP, number one, and have a national goal that we're all pursuing collectively, rather than confusing, frankly, those who care about this issue or those who we want to care about this issue. Why do you have different goals in your field? Why can't you have one goal? So I'm really proud of the fact that we have one goal and we're working collaboratively rather than in our own silo. And this way it brings us all together, I hope, to bring that collective energy to the work that we do and hopefully the lives that we're going to save.
Thank you, Jerry. Jim, I think this question might be for you, and I'm sure Jerry will have some thoughts as well from some of the work being done by the Action Alliance on this topic. But one of the topics that's coming up consistently in the chat as folks think about these tools is public perception around suicide prevention. With understanding that it is an issue that resources need to be devoted to it from the community level, and also working with partners to make sure that that is described appropriately through the media. So, Jim, is there anything that you might say about the connection of that public perception from the strategies or the specific approaches that are mentioned in the technical package?
Well, I think one thing that's clear is we need to have people understand the urgency of this problem. I'm not sure it's fully appreciated, not in the same way that we see, for example, opiate overdose appreciated now, even though suicide's taking over 40,000 lives a year, which is an incredible number of people, and that's just the deaths. So I wonder how we can better get attention to the public to this issue as well as to policymakers around this issue. I think that's a critical question. Some of the strategies, many of the strategies that we refer to in the technical package require resources to implement. And people need to understand that, the public and policymakers need to understand that. I also think, as we all know, suicide is a sensitive issue to communicate around. How can we communicate effectively in a way that raises attention to the issue without creating any sort of contagion or having unintended effects in suicidal behavior? So I could envision in the future, if we are able to get more evidence, some sort of strategy focused around reducing stigma around mental health and suicide, and creating better public awareness about the issues actually being a key strategy in suicide prevention. I think our evidence in exactly how to do that has a ways to go yet. So a very important issue that we need to consider.
Avery, this is Jerry. I would just add, we've done, to the best of my knowledge, 2 national surveys over the last 10 years. One just recently with the American Foundation for Suicide Prevention and another organization, and they were representative samples of the American people, and they were both overwhelmingly in support of suicide prevention, believed that suicide was preventable, called for the expenditure of additional resources to advance suicide prevention work. So that was really gratifying, and I'm sure you can probably find a press release or summary of that on the AFSP or the SPRC website or the Action Alliance website. That's sprc.org or Action Alliance for Suicide Prevention.org, and you can see that study that we've used as we make the presentation to policymakers and others about the public health salience of this issue and why it's something policymakers should look at. I also would say that in the recent past, when you look at the 21st Century Cures Act that passed in Congress after the election, there was a great deal of inclusion in that bill that was favorable to the work that we do. And I can tell you, I sit in Washington every day, and I'm very encouraged by some of the support I've heard around advancing efforts in the area of serious mental illness, certainly in suicide prevention. As we all know, SAMHSA recently released a grant that allowed for the national strategy grants, they call them, where suicide prevention across the lifespan could be addressed. And the Garrett Lee Smith Memorial Act has been funding states, tribes, and college campuses since 2005 because the law is written in a way that allows those grants to be provided to continue to do that work. Having said that, our work won't be finished until those grants spread to older adults, middle-aged adults, vulnerable populations, etc. And we all know that the federal investment is not quite where it needs to be, commensurate with the burden that's well documented. So there are organizations that are trying very hard to make certain that our policymakers are aware of the burden. And I would say to all of you that having access to data about your community is probably one of the most effective ways to engage your policymakers and your community leaders about doing something about suicide in your community. When you can make it real and you can make it local and you can make it something that they can see that their efforts and their support will do something about. And that's frankly how we've seen suicide prevention advance as successfully as it has since we got started back in about 1997, 1998 with suicide prevention as a nation.
Great. Thank you both for your replies to that question, which again, several folks did bring up. I do want to point out for the folks, there's a variety of questions about specific strategies and how to get help with specific strategies. For instance, how to start a community coalition. There were questions looking for resources about peer groups. And so what I would encourage you to do, again, is to look at both of these documents to think about these things very broadly. And then obviously, as Jerry mentioned earlier, SPRC's website is a great place with a searchable database with a lot of information and tools about how to do some of these specific things that we've been discussing today. For instance, how to start a community-based coalition. So there certainly are a lot of tools available for you about how to do some of this work, and certainly your comments have been helpful in thinking about additional tools that are needed as well.
Avery, if I could, I would also just want to add that our website has state pages, and if you go from, no matter what state you're from, if you go to sprc.org and you just click on states, information about key players in your state and their contact information will come up. And so if you're in this, for the first time and not connected to the larger community, please do visit that website. And every state in the country has a prevention specialist on our team who is assigned that state. So if you're looking for information, don't hesitate to reach out to the prevention specialists for your state at the SPRC. But clearly the state pages will give you that plus a lot more information that will be valuable to you.
Great, thank you so much.
And just to emphasize, one of the things we said at the end of the webinar, which is still very true, is that we have more work to do on developing user-friendly implementation tools and resources. And so that's something that we really hope to build on from this document and these resources in the future.
Absolutely. Well, we're coming towards the end of our time together. So Jerry or Jim, any last words before we talk about next steps?
I just want to thank you for your time and attention. I know it's a lot to ask for an hour and a half of anyone's attention, but we put a lot of work into this with the hopes that it would make your days a little bit easier by having everything been reviewed and put in one spot. And consider that you're not in this alone. We're all in this together and trying to do a really good job, and it's my honor to be a part of it.
I would just echo what Jerry said, and thank you again for your time, and also welcome your input and ideas. As Jerry said, we're just at the beginning, and it's going to need us all working together and being willing to share ideas and thoughts, and so we're open to that and look forward to getting this problem under control and really reducing suicide by 20% by 2025, if not more. So thank you all.
Thank you both so much for your time today, and to everyone who has attended this webinar. Just a couple notes about next steps. You will be receiving an email as a follow-up after this with a link to where you can view this recorded webinar. So the webinar has been recorded. You will receive a link to where you can view this. Please do share this with others who weren't able to attend today. I know several folks did ask that question in the question and answer section. Also in that email, we will send you again the links to both of these documents so that you can view them and review the wonderful content that they do have to offer. This today, of course, has been just a snapshot of what is in both of these documents. So we'll make sure that you have the link to both of these documents as well. And also, we will be sending you a survey after this webinar with some follow-up questions to you about this webinar itself. And please do, as both Jerry and Jim shared, please use that as an opportunity also to tell us about additional tools that you think would be helpful to your work. So thank you again so much for being with us this afternoon. We look forward to being in further conversation with you on this topic, and this will close our webinar. Thank you.